on Health Matters Television for Life. Maintaining good mental health. It's more than just positive thoughts and self-help strategies. With an estimated 1 in 4 adults suffering a mental disorder, it touches everyone. Join us for answers and understanding on how the brain works and what to do when it needs an adjustment. Right now on Health Matters. Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
Good evening, I'm your host, Teresa Lukens. It is the new year, it is time for making resolutions. But the promise of a fresh start is not a reality for a lot of people. Faced with depression and stress, the calendar change is not something everyone is looking forward to. Tonight, our panel of experts will help you take inventory of your mental health and, as always, take your calls and your emails. So let's meet the professionals. Dr. Paul Quinnett is a clinical assistant professor in the Department of Psychiatry and Behavioral Science at the University of Washington School of Medicine. He is also the president and CEO of the QPR Institute, which is nationally and internationally known for its work in suicide prevention training. Kevin Heid works in the Department of Psychiatry at Providence Sacred Heart Medical Center, where he specializes in children and adolescents. In addition, Dr. Heid is a clinical instructor for the University of Washington Department of Psychiatry and Behavioral Sciences and an adjunct professor at Whitworth University. Matt Layton is a clinical associate professor in both the University of Washington Department of Psychiatry and Behavioral Sciences and the Washington State University Spokane Medical Education Program. He has an MD and a PhD in pharmacology. Craig Lammers is a psychologist who specializes in behavioral health. He received additional training while interning for the Veterans Administration Medical Center. Dr. Lammers works at Rockwood Behavioral Health Center. And welcome to all of you gentlemen tonight, and thanks so much for being here.
Thank you.
This is an extremely broad topic when we talk about mental health, but it's finally one that is being discussed in this country, unfortunately because of some unfortunate incidents that have taken place. But Dr. Quinnett, when we talk about mental health, that umbrella, how many conditions or what conditions are we talking about?
Well, if you look at the National Institutes of Mental Health and other federal leadership, they estimate that about 25% of Americans will suffer from a mental illness at some point in their life, and some say it's more than that. It may be half of that. So what I tell my audience is if you look around at your 3 closest friends and they look pretty normal to you, then it's probably you who has something that needs attention. And we can do a lot of things, and people do a lot of things to sort of monitor and manage their mental health and take care of themselves. And we see more of that in the press all the time, and we have people trying to help. But I think everyone here will agree, just before coming on the show, that we're way understaffed. We have a manpower shortage, and it's creating something of a crisis in terms of where do you get care, what does it cost, who's competent, and those kind of issues. So we have a lot of work to do, but I think America's talking about it.
Can we call it an epidemic? Dr. Heid.
It is about to be. In Spokane, we have a number of psychiatrists, psychologists that will be retiring probably in the next 10 years at least. And we have absence of training programs. We have a demand, increasing demand for services, and that will be even more so with the new Affordable Health Care Act. We have many people that will be seeking services that will have great difficulty accessing outpatient services.
So we're going to obviously run into some stumbling blocks, even more so than we already have when it comes to addressing these issues. And we're talking about everything from mild stress and depression to more serious conditions like schizophrenia and those sort of things, Dr. Lammers?
Sure. I think it covers the whole gamut from the things that we would see more traditionally, depression, anxiety, adjustment disorders, all the way up to the more severe illnesses such as schizophrenia. And I think as Dr. Heid was saying about the epidemic, I think part of it is we're just refining our abilities to identify and diagnose much more clearly. So I don't know if the numbers are actually increasing as much as our ability to identify and potentially offer services to those who are suffering.
And when it comes to those services, much is being done. We don't want to sound as if there isn't some strides being taken and some progress being made. And Dr. Layton, towards that, even in our own community, there's training being done to train more people to recognize those who may be susceptible to suicide, and you're doing some work in that area.
Exactly, and when we're not intervening in these problems earlier on, they end up getting worse and worse, and people present to the emergency department or they require crisis intervention, and so they end up often interacting with our law enforcement professionals. So I'm privileged to get to work with Spokane Police Department in crisis intervention team training, and I'm on Police Chief Straub's Mental Health Steering Committee. And the hope is that we can work together across systems, whether that's the educational system, the medical system, the law enforcement system, to make it more seamless so people get the best care at the right time.
And Dr. Quinnett, your institute, actually, I love a comparison that your website makes to the amount of people that we have trained in this country to do CPR compared to the amount of people we have trained to recognize the signs and symptoms of suicide. Talk more about that and what your institute does toward that.
Well, we basically have a CPR equivalent training program. QPR stands for how do you question, persuade, and refer someone who may be exhibiting symptoms of distress or thinking about suicide. So it's early identification, early intervention, early care. And if you look at the equivalent in CPR, the question I often ask audiences is if you're going to have a non-hospital heart attack, in the public someplace, what city do you want to be in if you hope to survive? And what's the answer? Is it New York, Dallas?
It's Seattle, is it not?
It's Seattle.
I heard
Why
this.
is it Seattle? Because 1 in 4 adults in King County know CPR. So if you get hit by a flying salmon down at Pike Street Market, odds are those people from Seattle will knock each other out of the way to try their CPR on you. Plus they have paddles, Cracker Jack 911 teams, and great cardiac units. So here's the difference. I was just back from Ireland. In Ireland, the survival rate from a non-hospital a cardiac event is 6%, up from 1% 10 years ago. In any major city in America, it's less than 10%. But if you have a heart attack in Seattle, according to the New York Times, the odds of survival are 52%. And there's only one place where your survival rate is even higher. And I give the aid the person can think of this, in a non-hospital setting. It's in a casino at Northern Quest, because everybody's trained in CPR, everybody knows what to look for, and they have paddles and very quick response. And the survival rate in casinos for a heart attack is 70%. So ours is a public health mission to train everybody, every family member, one person in every family, how to recognize when a loved one is in distress, is depressed, and maybe thinking about suicide. So we want to identify early, intervene early, and treat early.
Can you talk specifically about some of those signs with us? And we can't go through the entire training this evening, but what can we be looking for?
Well, there's an old Welsh saying that no great misery goes unspoken. And so on the journey to a decision to end your own life, people will often talk in coded language frequently, oblique, indirect language. I don't think I can go on anymore. Will you take my dog and my stereo when I'm gone? I don't want to live anymore. They might tell their doctor, was this enough medicine to kill a person? That's not a chemistry question. That's a question about, I may misuse this medication to end my own life. And so we teach people how people talk about it. Sometimes they're very clear. Sometimes they just say, I'm going to take my life or I'm going to end it all. And that's not difficult to interpret. But because of politeness theory and the way people communicate about this, suicide is harder to talk about than sex. So we have to teach audiences how to recognize those kind of communications and then how to clarify what that person is saying. So there are behavioral signs, there are verbal signs, there are text signs. People will text their intention, to a Facebook page. There's a boy in Arkansas who texted, his last Facebook entry was, "Leave the lights on for me, Jesus, I'm coming home tonight." Now, if you don't know what a suicidal communication is, then you're going to look at that and kind of say, well, what does that mean? But if you've had a little bit of training, you'll know what that means, and you can take action on that.
Yeah, and the social media certainly has added a whole different element to recognizing those signs and to getting your friends and family to recognize those signs. And Dr. Heid, you work with teenagers and the parents of those teenagers and adolescents. And,
I do.
And is it basically the same in your work in recognizing those signs, or do teenagers and kids react a little differently when they're showing signs of distress?
Teens communicate their distress in a variety of ways. Sometimes the words, like Dr. Quinnett is talking about, kids will say, you would be better off if I were not here. Or, I've been a burden to you because I've been depressed, I've cost you money, I'm angry all the time, I've been a burden to you, and I'm not going to be anymore. Or they will start giving things away, or they will act out more, or they will withdraw. They'll do a number of behavioral things that will send the message to their families that they're in trouble. And as Dr. Quinnett says, it's important for families to be listening and be watching and try to understand what those statements and behaviors mean.
Well, and to pull them out of a teenager, because we all know teenagers can be a bit dramatic.
Yes.
I have 2 daughters. I've been through that. And so it's hard sometimes as a parent not to say, oh, you're just being, you're overreacting, you're being dramatic, go to your room, cool off. It's hard, it frightens me to hear you say that, because it's, as a parent, could I be missing those signs? And so is that where some better training for people can come into play?
Yes. And whenever we talk with kids, we always want to keep in mind how important it is to validate what they're saying, validate that we've heard what they're saying before we tell them what we think they mean.
Okay.
I also think that this speaks to the importance of not only training and better identifying within families, but I think, as Dr. Heid is saying, especially when you're talking adolescents, my experience has been they may most likely turn to a good friend before they will turn to an adult. And so I think even teaching teens and adolescents the signs to be looking for, what a friend is going to be saying to them, oftentimes the same things we've heard with a little different language to it. But it's not unusual for us, in the work we've done at Rockwood with suicidal people, teenagers, that usually it's a friend, it's a peer who has alerted another adult to what that adolescent is thinking about.
That's a great point.
Mm-hmm. And so often, again, it's difficult to find the care and to find, when Adam Lanza went into Sandy Hook Elementary School and took the lives of 20 children and 6 adults, there was an article that was written shortly after by another mother who said basically she could be the mother of Adam Lanza because she was running into the same roadblocks and the same obstacles that Adam Lanza's mother had encountered, and the frustration, and that gained a lot of attention. It brought a lot of attention to the issue and to the problem that we have of just getting the care, especially for our kids. Is that not true, Dr. Layton?
Yes, and we've dealt with the stigma of mental disorders and the generational impact of slowly talking more and more about this. And now we have to face the barriers of someone who's admitting that they have a problem, they're acknowledging that they need help.
Finally taking the stigma off of that.
Taking the steps, and there's barriers. And the last thing that a hopeless, helpless, depressed person needs is an additional barrier. And so one of the things I wanted to comment on about that are basic things that parents and families can be watching for in themselves and in their kids is, are you having trouble sleeping? Are you seeing changes in your appetite? Eating too much or not eating at all? Changes in your energy level, changes in your enjoyment of your usual activities. Are you not even caring about your usual activities? That's the slippery slope down the depression's trail. And at any point when you start to distort your thoughts, you do start to think that the world would be better off without you. And at that point is when those around you need to intervene and recognize and go ahead and reach out. Ask the person what they're thinking. Don't be afraid that you're going to put the thought into their head, because it's already there.
And that has been the thinking in the past.
Sure.
Well, but that's a protective myth. It says, if I intervene, if I ask Kevin, I say, Kevin, you look really down, and you've not been enjoying yourself much. You don't play golf anymore, or whatever your habits are. And if I say to him, I'm concerned that you might be thinking about taking your own life, and he says yes, what have I just done? I've taken on a burden of care for his health and safety. Okay, so there's a protective myth that says, if they talk about it, they won't do it. Wrong. Okay. If I ask them, it'll put it in their mind. Wrong. These are myths that protect us from expanding our circle of empathy and saying, I can bear your pain with you. It's a huge step that people have to take to lean into somebody's suffering and say, I'm worried about you, I'm concerned about you, let's see what we can, let's talk. And you have that first opening conversation, which you have to be prepared for. Because if you tell a teenager, I know you feel like you're a burden, but you're not, and we love you, and they may weep, they may start crying, and you may start crying. And so this is we have a lot of fun teaching this, but it is very rewarding to be able to get people to do that first level intervention. And if you do it upstream far enough, as Matt was saying, if you do it early enough, when the first symptoms begin to come, then you can avert these downstream terrible, costly consequences, including the loss of a life. There's a psychologist at University of Palo Alto, Ricardo Munoz, whose work is on preventing depression. Not waiting until we have the symptoms and now we'll go put the treatment on it, but getting upstream far enough in child development that you can head this stuff off and create happy, resilient kids who can manage conflict and stay out of trouble and know how to monitor their symptoms.
And we know enough about family risk factors. We know that it runs in families. And if you have parents, grandparents, aunts, uncles who have had depression, who have had bipolar disorder, who have had schizophrenia, you have risk genes. And so we need to start screening and identifying as early as possible.
How young are we talking about?
Well, I think when you see the pre-kindergartner having problems with behaviors, disruptive behaviors, anxious behaviors, there's probably something going on in the background. Potentially abuse, neglect, a dysfunctional family environment. And those are some of the early seeds of stress that then lead to chronic stress, which leads to depression and anxiety.
Which can also lead, it can manifest into even more serious mental conditions. If a person isn't necessarily suicidal but carries that depression and that stress with them, it can manifest in other ways, can it not?
Well, yeah, if you look at the World Health Organization's projections just from the last year, actually, they look at what's called a DALY, which is a premature disability or death. What are the causes of that? And for centuries, it's been infectious diseases like malaria or dengue fever. Those kind of things cause people to get sick and die before they need to. But guess what's second now? Untreated depression. And in parts of Asia, untreated depression is now the leading cause of premature death and disability. So if Bill Gates and his foundations and these people solve the malaria problem and they solve some of these other infectious disease problems, it's going to be a mental disorder leading the pack for why people can't get to work, why they are not functioning, why they're unhappy and ending their own lives. I mean, we lose 1 million people a year to suicide in the world.
That's epidemic.
Well, we don't know what the historical patterns have been because, and lots of countries don't report, but let's take it right home, right here. If we don't do something different in our state, in the next 12 months, 1,000 Washingtonians will kill themselves. 1,000. And 2 of those a week will be youth. And what are they going to die from? The number one cause they're going to die from is an untreated mental illness, most likely depression. And they're going to go for care in our systems if they can get in, or they're going to go to primary care nurses and physicians. And they're going to present with illnesses that he teaches all the time. This is how an older, depressed male presents. They're not crying, they're not talking about, and they have loss of appetite, they have poor sleep, and the symptoms that Matt just went through. So these are choices we have to make from a public health point of view. What do we want to do about this? Because at the end of the year, this is what we're going to have if we don't take action. And I'll just add this, and I'll stop talking, but there is legislation just passed last year to require training of mental health professionals in suicide risk assessment, treatment, and management, because death by suicide is the terminal phase of these untreated illnesses. That's really what it's about. So the suffering is so great that people have to stop it themselves. And there's a bill pending going to be introduced in the House next week that would require similar training of primary care physicians, chiropractors, nurses, physical therapists, and others who have contact with patients who are likely to be treated for something other than the depression that's driving their distress and often motors their other symptoms.
Okay, we want to include some questions from you tonight, and we have Nena from Spokane Valley calling in with a question for our panel. Good evening, Nena.
Hi.
Hi, what is your question?
My name is Nena. I have been mentally ill since I was 6 months old. I am now 63 years old, plus a week or two. And I was in therapy for 30 years. I no longer feel I need it. I was on a medication that gave me something called neuroleptic malignant syndrome. It was an antipsychotic drug. And it was just awful, just absolutely awful. My son made me go to the hospital. I had a fever of 106. When I got to see my neurologist 4 years later while I was trying to get rid of the migraines in my eyeballs as a side effect, and he helped me, Dr. John Worst, and I'm still having problems keeping that in check, but I rarely get depressed. And when I do, I go right straight to the Bible, and it helps. It makes such a huge help. I am on some clonazepam and some prazosin because I used to have really terrible bad dreams. So my shrink, he kept me so that I never had to deal with that. And I can even remember a nightmare starting to come, and it just went away like a flick of a light switch.
Nena, do you have a question for one of the doctors this evening regarding your condition?
How do they feel about people that have survived neuroleptic malignant syndrome, and how do you think that we should be treated?
Dr. Layton?
Take that, yes, because neuroleptic malignant syndrome is a potentially fatal condition. Nena, I'm glad you survived. And our medications are not benign. We use psychoactive medications a lot, and there are a lot of mental disorders that is the standard of care. We need to use talk therapy as much as we can, but times when people are psychotic and require antipsychotic medication, the benefits are important, but we have to talk about the risks, and we have to make people aware, family members, the patients themselves. They have to try to understand what it is that this medication is doing. And this is difficult because often you might be paranoid and very terrified of the medication itself and sticking with it. But in fact, neuroleptic malignant syndrome is something we need to talk to patients about. It's required by the Food and Drug Administration. There's a black box warning about it on antipsychotics. So it's a very scary, very terrifying situation. And it sounds like you have some residual, Nena, where there's a thing called oculogyrate crisis, where in fact your eyes the muscles around your eyes actually have spasms and contract. So we're not taking these medications lightly, and we can't expect primary care providers to manage very complex psychoactive medication regimens when they have not had the specialty training for it. And I work enough with primary care providers that they agree with that. They understand schizophrenia, they can diagnose bipolar disorder, they want to refer to someone because they know these medications have these kinds of risks. So again, Nena, I hope you're getting good care now, and I'm just glad you're alive.
All right, are we making, I'm sorry,
I was going to say,
Dr.
I
Lammers?
just wanted to point out, and I appreciated her comment too. I think she said she'd been in therapy for 30 years. And I'm just really pleased because it sounds like that was a very beneficial process for her. And for her even to make reference to her faith, reading the Bible, you know, oftentimes part of what we do in therapy in that way is identify those sources of support, sources of encouragement that we can turn to. Those could be a religious organization, family members, the activities that we try to structure and engage in, hobbies, things that just bring us pleasure, so that as we hit those downward spirals, we can turn back to those to kind of give us a lift, to pull us out of that. And it sounds like she did a very good use of those 30 years in being able to identify those.
Mm-hmm. Is the idea to do as much therapy as possible to avoid any kind of medications, or are some mental conditions just going to require medication?
Well, I'll say about 30% of people in this country are treated involuntarily for their mental disorders. And so there's an inherent difficulty in establishing the doctor-patient relationship. And a lot of that is around a lack of insight. And people don't want to have a mental disorder. It's still very stigmatized. They don't want to take these medications that cause a lot of physical problems. And so, however, when somebody's acutely psychotic, when they're dangerous to themselves, they're dangerous to others, they're homicidal, they're hearing command hallucinations that they believe God is telling them to do things to people. In those cases, we need to treat them with emergency medications. Mm-hmm. But on the side of dealing with anxiety and early depression and recognition, the kinds of things that we've been talking about, adequate sleep, good nutrition, exercise, getting outdoors, acknowledging your spirituality, finding meaning in life, you may not need a medication.
Which we want to try to avoid at all costs.
Because there are risks.
Okay. Let's take another phone call. We have Julie calling from Medical Lake. Good evening, Julie.
Good evening. I want the panelists, please, to comment about the growing prescription drug addiction problem that seems to be sweeping the nation, please. Thank you.
All right. Thank you for your question, Julie. Who would like to answer?
He's the pharmacologist.
That's true.
He knows all about it.
Well, this would be essentially the oxy problem, the reference to the OxyContin problem, and it is a huge issue, and it often starts very innocently with exposure to these opioid medications at parties, adolescent parties, where they get into the parents' medicine cabinets for appropriately prescribed pain medications and other things, and they then misuse them and end up getting addicted. And so we have seen exponential increase in the number of accidental overdose deaths, in not just in Washington State, but the Vermont governor in his State of the Union address identified as the #1 problem for Vermont right now. Excuse me. So it's something that when you talk about mental disorders, we cannot separate out addictions.
You put that under that umbrella of mental disorders.
Correct. We diagnose them together. And often what we find is that we have a coexisting problem of mental disorders, addictions, and pain.
That's interesting. I had no idea. I would not have put the two together. And why is that? Why do we, a drug addiction which starts out somewhat as a choice by the person to take the drugs, and then they become addicted. So how does that fall under that category of mental illness?
Well, self-medicating is something that people have talked about for a long time.
Okay.
And whether one believes in that or not, what you find is a lot of people with bipolar disorder, with post-traumatic stress disorder, we have returning veterans with post-traumatic stress disorder who have traumatic brain injuries, they have amputations, they have post-traumatic stress disorder, addictions, and pain. And so within that syndrome, people often can't differ between the psychological and the physical pain and anguish. So they are experiencing anguish psychologically, which translates to, I feel like I'm having a heart attack, I feel like I'm having a headache, I'm going to go to my primary care doctor. I'm not saying it's depression, I'm not saying it's panic attack. I have to get the physical part worked out, and often someone says, well, you're in pain, I know how to fix that. I can write a prescription for a pain medication.
I see.
Out of the empathy of wanting to help in the short term, we can create a longer term problem.
Okay, let's take another phone call. Oh, I'm sorry, Dr.
I was going to say
Heid.
about the self-medication issue, Dr. Layton's exactly right. We see many kids who are in extreme psychological pain and are suffering, and they're looking for some symptom relief. They go to a party, and they find drugs, and they find symptom relief. And they start using more and more and more. Unfortunately, the time of adolescence is a crucial period of development where one learns many things, but very importantly, learns how to manage life, learns how to manage affective discomfort, to take responsibility for life, to maintain goal-oriented behavior, and gain a sense of power that one has ability to affect their life's outcomes. Well, if this youngster is high or on drugs throughout a good deal of adolescence, then they miss a very important part of the adolescent experience, and they experience some impairment in terms of their ability to manage self, and they remember the drugs work.
So
and
sad.
they continue to use, and finally they're addicted. So I think that there's this, that's one of the reasons why addiction is included as a psychiatric disorder, because it is impossible to separate the two.
Okay. Let's take Jesse from Greenacres. Good evening, Jesse.
Good evening.
Hi, do you have a call, or I mean a question?
I do. My son, I believe, is probably mental ill. It's been going on probably, he's still living at my house. He's 30 years old. He's in alcohol treatment. He also is on the PSHS for mental health. And I'm finding that he's caught in the middle. My insurance won't cover him. And he believes he's Jesus. And he's been going through these programs for years. And I'm not seeing any result out of it. And he has no place to go. They don't take him in and really take a hard look at him. He's been arrested. He's been hospitalized several, probably 4 times. He's been kept at Sacred Heart Medical Center for 2 weeks under observation. They've given him medication, and yet he just keeps coming back, and they don't do anything. So I'm not sure how to proceed from here. The police even let him go. Rather than dealing with him, they'll find him out on the street corner screaming at cars, screaming that the people are the devil, and they'll pick him up and they'll bring him back to my house. And I've had lots of conversations with the police at my house, and they know it. And I've called 911 when he's come here. I don't feel I'm personally in danger, but I do feel that he definitely is deranged. He doesn't have any real conscious understanding of what reality is, and yet I find facilities around Spokane that just kind of push him off and not doing anything. He's attending Sparks. He goes and sees a psychologist. I'm hoping that it would be a psychiatrist at DSHS, and yet it goes on, and this has been going on for 5 years.
All right, Jesse, we hear the frustration in your voice. We certainly understand. I want the doctors to try and help you find some course of action here that might be able to help you and your son. He's extremely frustrated. He's working within the system that seems to be fighting back and helping him. His son's 30 years old, so he's certainly of age. What can Jesse do to help his son get the treatment he needs?
Well, he is definitely having symptoms of a mental disorder, Jesse. You're correct. And in fact, he sounds delusional at times. And what you also mentioned, though, was Spark, which I believe is the Spokane Addiction Recovery Center. And so this may be just what we were talking about, which is, does he have both a mental disorder and some addictions?
So,
are you still on the line? I guess the question would be, There are drugs that can produce symptoms that are identical to paranoid delusions, the grandiosity of believing that you're Jesus, spreading God's message, and this could be related to, not to jump to any conclusions, but it can be related to methamphetamine, it can be related to cocaine, bath salts, some of the other street drugs that will make people psychotic. And in that moment, when they're in the emergency department, agitated, psychotic, potentially violent, it all looks the same at that moment. So the question would be, does he have a period of time where his son gets into the hospital, gets diagnosed, gets treated, gets stabilized, then goes back out? Does he continue on the medications? Does he follow through with outpatient care? Is he using addictive substances? Because all that's going to influence the fact that he sounds like he's in this revolving door where he's bouncing off the systems, including the emergency departments, law enforcement, and mental health. And
because, I mean, he's a 30-year-old adult, does Jesse have any leeway here as to how he can help his son, or is he kind of stuck between a rock and a hard place when it comes to his adult son, who obviously needs some care and some attention? What can he do as a parent? I could hear the frustration in his voice. He doesn't know where to turn at this point. Where does he turn? Do we have an answer?
I don't want to be pessimistic, but I've traveled a lot, and America has failed his son. It's not his fault. It's not the people here.
He needs
it is
some help.
Our entire culture fails to recognize that some of us are not going to thrive. Now, I'm old. I'm the oldest person in the room, so I come from a day when we had a state hospital at Eastern State Hospital and at Northern State Hospital, where I did my internship, where we had several thousand patients, and we had gardens and farms, and we had work, meaningful work. We had occupational therapists who taught how to build a bench. We actually had, at the turn of the last century, or the century before that, we had what was called pastoral care. So if you were so ill from a brain disorder that you couldn't function in society without the assistance of too much alcohol or this or that or the other thing, and you simply couldn't make it. I mean, it wasn't that, we think of now, we say, well, that was unkind because those people were there against their will. Well, that's true in some cases, but on many times they were there volitionally, and it was a reasonably good placement for them. I'm not talking about going back to the snake bits of the 50s. I'm talking about when there was a compassionate perspective on the mentally ill who said, you're not a problem to us. You are one of our family, you're one of our community, and we're going to care for you. I was in southern Spain many years ago, and there was a man like this, about 30-year-old fellow, walked into a tapa place where we were having beers one afternoon on the beach in the Costa del Sol, southern Spain, and he was clearly mentally ill, okay? And the bartender smiled at us and said in Spanish, don't buy him any drinks, we'll take care of him, and he was there, and he wandered around, and he was harmless, and everybody knew who he was and where he lived, and the whole village sort of took care of him and looked out for him. So anyway, we don't have that attitude currently operating in the country. So I've got something going on my
earpiece.
But as a result, Jesse, as the parent, may be in the position of someday saying, I'm not going to take him back home. I don't feel safe, or I do feel threatened, because right now he said he's not. But if he's so frustrated that they just bring him back to the home because he's an option, there may come a time where he has to say, in order for him to get a higher level of care, I will not take him back. And that's the system failure as well, if we're making parents have to say, I can't handle my child.
And that may be the only way to access involuntary treatment, because Jesse's son is probably not going to access on his own.
Okay. That's a tough one. Kimberly is calling from Edmonton this evening. Good evening, Kimberly.
Good evening.
Thank you for waiting. Do you have a question?
Well, I have a question and a comment. First of all, I'm a type of counselor. I'm not going to talk about what type of counselor I am at the beginning because it's kind of shocking. But I give my clients talk, and I give my clients options in what to do in life, because what I find when they're depressed is that they don't know what to do. And they don't know what to do about the sister-in-law that's bothering them. Or, and it sounds like such simple little things, but in a person's life, there are humongous, momentous issues. And those little tiny dust bunnies become one great big avalanche of hell for these people to live in. But if there's someone there to say, well, you could talk to your sister-in-law like this, or this, or this, and give them options after they've seen their doctor, after they've seen their family members or spoken to their family members. And I'm talking about using the resources that we have. Resources sometimes fail because we're not telling them that they've got options and what they can do. And when you're depressed and you don't see any options, I think that's a pretty important place to be. And I get letters and calls on a consistent basis telling me that we have saved people's lives and we have saved people's families, etc. And it's absolutely heartbreaking. I love them, but it is also heartbreaking. I also wonder, where is the help for those on the front lines, for those that are counseling people and don't have anybody to talk to? When I work with police departments, I find often that, the detectives, when they're working on a missing person or homicide case, they've got someone to talk to. I find that most counselors that I deal with, that are my clients, don't have anybody to talk to. And that's what I'm concerned about. And this is where I wonder, do we have the resources to tell depressed people that they have options, things that they can actually do? I'm not talking highly psychotic people. I'm talking people in menopause, people in menopause, people in everyday lives where depression is seriously affecting them, but they are not entirely out of control.
Okay. Kimberly, thank you so much for your comments this evening. And she brings up an interesting point, giving people actual tangible things that they can do to come out of the depression, to fight their way back and to become, active members of society and feel useful and resourceful. It's obviously something you probably use in your practices.
Well, I think she's bringing up, as she said, her style of counseling that she offers sounds like it's much more directive, much more of giving of ideas, maybe even some basic instruction, particularly for people who are depressed. There are so many different varieties of therapy out there, from the therapist who's very quiet, fairly passive, to therapists and counselors much more like her, who would say that a depressed person, either in the confused thinking, the lack of motivation, really needs to be more directed. How do we help them to be more proactive? How do we help them to ask the right questions of their physician or other people who can be there to offer resources for them?
So they can find that counseling and that therapy that really does apply to what they need.
That's the thing, and I think counseling has a unique aspect to it, that it has to be a good fit for your personality as the client. And so there are other folks who would not fit well with her style, while her style would be very appropriate for a group of people who would be looking for that.
Well, that's an excellent point to make. You really have to find that fit that works for you also, just like you would with your primary care doctor or any other doctor specialist that you would see. We touched on just very briefly, or brought up the topic of post-traumatic stress disorder. We are welcoming home many of our service people now, and we're seeing more and more of this. This is going to be a huge problem, just dealing with that aspect of it. And we've already talked about the lack of doctors and the treatment that we're going to encounter. Is this going to be the problem that we're anticipating, bringing those service people home?
Yes. We have 60,000 coming to Washington State alone. The wars are winding down. They're going to be discharged. They have to go into a transitional phase from being given orders, knowing their mission, having commitment and purpose, a reason to get up every day, to a civilian life. And I'm just on the phone today with a group in another state called the Purple Star Foundation, founded by a man whose son was a Marine Corps officer and did 3 tours, I think, in Iraq and Afghanistan, and came home and didn't make the adjustment and ended his own life in a high-speed single motorcycle accident. probable suicide. And he's a grounded guy, and what he's talking about is the service ends your service today, and you're now a civilian. There is no transition from being a warrior to being a civilian. If you turn it all around, and I'm a military veteran, so when you are a civilian and you go to boot camp, what do they do to you? They turn you into a soldier, and they do it in a matter of 6 to 8 weeks. They change who you are so that you can go and do things that you couldn't have done as a civilian. But we don't have a decompression transitional period for our warriors when they come home. My youngest brother came home from Vietnam in 1969 after a year of combat in the Tet Offensive, and he was literally discharged in San Francisco 3 days after leaving combat, and was in Pullman in my apartment when I was in graduate school there. And I took him fishing on the Snake River, and he said, don't pound on the door in the morning, because I've been sleeping in a jungle with a pistol for a pillow, and I'm a little jumpy. Now that is nutty when you think about it, in terms of decompressing from the war. And so these soldiers are coming home, and everybody listening to this program, all of us have something we can do to ease this transition for them. Be more tolerant, be more compassionate, understand kind of what their frame of mind is and what it's like to sort of demilitarize your personality. This is not an easy thing to do. So we have a lot of things all of us need to do to be aware of this, because it's men and women now, and their suicide risk has doubled the population. We're losing 22 veterans a day to suicide in the country. That's from all our wars, these included, but 22 a day. 1/5 of our suicides are veterans. So we got a lot to do.
A lot of work to be done. We want to take another phone call, try to get in a few more before the end of the show. Lila from Airway Heights is calling this evening. Lila, good evening.
Good evening.
And your question?
Well, it's kind of a problem. I don't know how to deal with this. This lady called here, got my number some way to call to get a hold of my son, and she's out at Eastern Hospital. Now she's calling me every night and talking for about a half an hour, and I hate to hang up on her, and I don't know if I hang up on her or if she'll get worse, or if she just needs somebody to talk to. How do I handle it?
She's a patient at Eastern State Hospital.
Yeah, and I don't know. And she calls me almost every night and talks to me. And do I sit and just listen to her, or do I hang up on her, or would it make her worse? Or
well, that is an interesting question. Who would like to answer that?
Lila, I'm just wondering, have you talked to either the people at Eastern State Hospital or your son about this?
She called my son. My son was a friend of her ex-husband, and she couldn't get a hold of him, so somehow she got a hold of my number, called me to get a hold of my son. Now she calls me all the time. My son won't call her back.
Right. Have you talked to law enforcement about this?
No, I don't want to. I don't think she's I don't think she's very harmful. I don't know, but I just.
So she's not threatening you or anything like that?
No. She just talks.
Well, I think you should talk to the Eastern State Hospital staff there and let them know that you're getting these calls and you're uncomfortable with them and you'd like them to stop.
Yeah, I don't want to. I don't think she's. I hate to turn. I don't know if she just needs somebody to talk to, but I don't want to make her worse.
You sound like a very nice lady. I would enjoy talking with you too.
I don't want to make her worse, because I'm not a psychiatrist or anything.
Well, it's so nice that you're being so understanding of that, Lila. Dr. Lammers?
Well, and I think you need to realize, too, she's in a situation and a place now where she's receiving care. It's very structured, and you're kind of gently backing out of her life at this time. She's going to be well cared for and helped through that. So you aren't putting her at any greater risk at this time of her possibly harming herself or making things worse if you would like to step away from that.
Right. Okay. And she won't be punished. When you call the staff at Eastern State or the administration, don't be concerned that somehow this lady is going to be punished. She's going to be provided with some, like Dr. Lammers says, some assistance, and it may be that her staff is unaware of the degree of her loneliness and sense of isolation. And I think they would appreciate a call from you and informing them about how they might want to intervene in terms of treatment.
Okay, yeah, it's an interesting question. I don't know that I've ever come across that one. How many patients do we currently have at Eastern State Hospital or in the facility out there? Do we know? Because it has scaled back quite a bit.
About 300, yes.
About 300.
And we have both forensic, so civil commitment as well as forensics. So.
And is there still Western State Hospital on the other side of the state? And they're in the same sort of situation?
It's bigger, and at one point, as Paul was talking about earlier, they had 10,000 patients at Western, and I believe Eastern had about 3,000 at one point. So it's about a tenth, but they're all involuntary at this point.
So again, it kind of goes to that, what do we do with some of these severely mentally ill people? We can't keep them in the jails. Quite often we find them on the streets. We end up, with families that are frustrated, like our previous caller.
We have evidence-based approaches now through, for example, the Substance Abuse and Mental Health Services Administration has 6 or more evidence-based practices. And for one example, it's called assertive community treatment. And an ACT team works specifically with the most severely, persistently mentally ill who often have addictions and they're homeless. Right. And so they have lower caseloads. You have a team with hopefully a nurse, a caseworker, a social worker, and you all work very closely. Not enough people have access to that level of care.
Right. Okay, let's take another phone call. Val calling from Lethbridge. Good evening, Val.
Good evening.
You have a question?
Yes. Well, I've suffered from depression and post-traumatic stress for many years now, and I've tried all kinds of medications and therapies and gone to psychologists and therapists, and they've tried numerous kinds of medication that were just absolutely horrible, terrible side effects. And I was getting quite desperate and suicidal, and I came across a book called Body, Mind, and the B Vitamins. And it had many cases of people from depression to bipolar to even schizophrenia that had been cured by mega doses of B vitamins, so I tried it. And it's the first thing in many years that had helped me. And I'm just wondering, and I recommended it to some of my friends also, or people I knew that were having problems, and it helped them as well. So I'm wondering why doctors aren't recommending that for things, if it can help post-traumatic stress syndrome and depression, even shingles. A friend of mine had helped their shingles, which is from stress. I don't understand why doctors aren't recommending this for people.
All right, Val, thank you very much. Dr. Layton.
I would say that, as we were talking earlier, we start with the basics. I teach first-year medical students about human behavior and behavioral medicine. And we teach them what's good for the doctor as good for the patient. And so sleep, adequate diet, exercise, those basics, and including adequate nutrition. And it's one of the reasons why we check for vitamin B levels, folate levels. We do, when somebody has a mental disorder, as a physician, I thoroughly assess them and I do laboratory tests to make sure, for example, that it's not anemia, or some kind of autoimmune disorder, or a problem with their thyroid gland, or something like that. So we do basic metabolic tests, we do blood counts, and within those we can actually see if somebody has terrible nutrition. And in fact, the medications that we prescribe for depression, anxiety, and PTSD, if you don't have the natural building blocks and nutrition, the medications can't do what they're supposed to. So you have to start first with getting the body adequate nutrition, including B vitamins.
Any evidence to show what Val was talking about with mega doses of B vitamins helping in any way?
Not that I know of, but it's definitely very common in older people that are beginning to have memory problems. And if we have a patient come in for an assessment for early memory problems or for dementia, possibly, I always check vitamin B12 panel, look at folate, because we can give them mega doses and you can often see improvement in cognition. So, I don't know as far as PTSD, but I don't discount it. I'm open to these things as long as it's reasonable and really involves those basic 3 things.
Is that one of the first things that you can do, is have some blood work done to sort of see what's going on, some of that initial testing going on to determine some of that?
If you are tired, if you're not enjoying your usual activities, you don't have the energy or motivation to do anything anymore, you're not sleeping, you don't feel like eating, then yes, you go to your doctor and you hopefully get a thorough evaluation. So I certainly agree with what she was saying, that physicians should be doing an adequate assessment, and that includes for depression as you would for somebody who just has unexplained fatigue. They're just tired all the time. We, of course, are looking for physiological explanations first.
Okay. I want to get some final thoughts on the topic. We're coming to the conclusion of the show, and you know, it's big and broad, as we mentioned, and a lot to talk about. But again, we are making some strides in our community and in our nation and internationally towards a better understanding of mental illness. Dr. Quinnett, some final thoughts?
I've been around a while, and I'm cautiously optimistic about a number of developments that I see, and including on the technology side. I'm part of an international society for internet-based interventions. And for example, the Australians have a program called Mood Gym, which is free, and it's cognitive behavioral therapy on your smartphone. And I see all kinds of health interventions coming to help people better manage their diets, their sleep. You can now have your smartphone tell you when you're not sleeping well, and your physician can track that from his computer in his office. I look at what I see happening globally, and I'm kind of like, okay, if we can start getting our hands around this, and we can knock down our fear and our ignorance about these are brain disorders. These are neurochemical things that happen from external stress and all kinds of reasons that Matt was talking about, Dr. Layton. But I'm optimistic, and of course I always am. I've lived on soap bubbles my whole life. So.
Well, it's good to know.
Yeah.
Dr. Layton.
Well, Sigmund Freud said a lot of things, and a lot of them I don't agree with as a psychiatrist, but one of them I do agree with. He said, happiness is to love and to work. And what I find is that meaningful relationships and having a productive, it doesn't mean that you're a breadwinner. To work means to do something generative, to produce. And for me, I'm fortunate that I love my wife and my children, and just wanted to say hello.
Very nice. Dr. Heid, some final thoughts?
Over the last 30 years, we've made sizable inroads in terms of our understanding about diagnosis and treatment of mental illness. That's the good news. Now we need to make sure that we have the professionals there ready to treat.
Okay, thank you so much. And Dr. Lammers, finally, just quickly.
Well, and I think people should be encouraged too that the therapies that are available out there are becoming more evidence-based, as was referred. That these therapies have been researched very well, and they've been proven to be very effective. And I just think that should be hopeful for people who are struggling, that there are ways that they can really reach out that can be effective.
All right. I want to thank you all for being here this evening. Thank you so much. An important discussion. And that will wrap things up for this show. We are going to be back on February 20th when our topic will be heart health. Until then, thank you for watching. I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.